Welcome everybody. I think we're ready to start now. Welcome everybody to this evening's webinar. Thank you for joining us all tonight on this webinar on research into age-related macular degeneration. My name is Geraldine Hoad. I work in the research team at the Macular Society, which is a charity which funds medical research and provides advice and support to people living with macular disease. So I'll be asking questions tonight. And thank you to those of you who had already sent questions in. We will be addressing those. But we also want you to ask questions about research on AMD during the event. So please post your questions in the Q&A box. It's the little speech bubble at the bottom right of your screen. And we'll do our best to answer as many questions as we can in the hour. To change how the speakers appear, click the three buttons at the bottom of the screen next to the red phone icon. Then change layout and then select the sidebar or spotlight setting. If you'd like to turn on captions, please select the CC button icon at the bottom of the screen. These captions are automatically generated, so may not be perfect. Unfortunately, we won't be able to answer any questions about individual cases. We would suggest you talk to your healthcare professional if you have any concerns about your health generally. Tonight's webinar is being recorded and you'll be sent a copy of the recording. And this event has been organised by the National Institute for Health and Care Research, or NIHR for short. The NIHR is a government-funded body that funds research in the NHS, public health and social care. If you're interested in learning more about research and to search for studies you can take part in and sign up to be contacted about studies that interest you, then please visit the Be Part of Research website. Just search Be Part of Research, and remember you can take part in as many studies as you like, even if you don't have a health condition yourself. So they're always interested in healthy volunteers as well. Now I'm going to be putting your questions tonight to Professor Susan Downes and Dr. Samantha de Silva. So I'm just going to ask them to introduce themselves. Susie, would you like to introduce yourselves first?
Hello, I'm Susan Downes. I'm one of the consultants at the Oxford Eye Hospital. I specialise in medical retina, and that includes all the diseases at the back of the eye, including age-related macular degeneration. I'm also a professor of ophthalmology, working in research in the Nuffield Laboratory of Ophthalmology, the Nuffield Department of Neurosciences at the University of Oxford.
Thank you very much. Sam, would you like to come on camera and introduce yourself? Sam? Have we got a problem with Sam?
No, I think Sam's
coming. Yeah, sorry, I just had a camera issue, but
don't worry.
So I'm Sam de Silva. I'm also a consultant ophthalmologist at the Oxford Eye Hospital and a research fellow at the University of Oxford, researching AMD and inherited retinal disease.
Lovely, thank you very much. So we've got two very knowledgeable people here to answer your questions. So let's dive straight into the questions that you've sent in. And the first one we're going to start with is, what is AMD and what is the difference between wet and dry AMD?
Right, well, if I can start with that one, and Sam will chip in if she wants to add anything. Age-related macular degeneration, it was first described back in the late 1800s, and since then we've realised it's a title for many different disorders. But in the interests of brevity, we've divided it into three, which is early age-related macular degeneration, early AMD, and then there are two more advanced forms, which is the wet and the dry. Now, it's very tempting to call everything that's not wet dry, but that is not helpful, because dry refers to the advanced form where there is cell loss and tissue loss, leading to central visual impairment. So just to reiterate, early, which most people don't have any symptoms, which is characterized by some changes that we see as clinicians or optometrists at the back of the eye, either by looking in or with imaging. So most people don't have symptoms with early. And I would like to point out at this moment in time that with early, not everybody goes on to develop the late or the advanced type. So for example, if 30% of people over the age of 75 have got some form of AMD, some form of aging change at the back of their eye, only 6 to 8% of that 30% will go on to develop the advanced form. So it's not inevitable if you have the early type that you'll go on to develop the late type, the wet and the dry. I'm sure we'll have to refer back to this, but that's the basic, just to get us kicked off.
Thank you very much. The terminology can be confusing, I know. So the next question is, what are the different treatment options for dry versus wet macular degeneration?
So I can take that one. So really, in terms of treatments, up to this point, our main treatment options have been for wet or neovascular AMD, and that has been in the form of injections of a medication called anti-VEGF, and there are different forms of that or different drug names that we use in clinic. And essentially, in wet or neovascular AMD, what happens, as we've said, is you get a growth of abnormal blood vessels underneath the retina being the light sensitive film at the back of the eye that picks up the picture that we see. And when you get these abnormal blood vessels, they leak and bleed, and that's the reason for vision being affected and patients developing symptoms. And so what these drugs do is they help to shrink those they help to sort of stop those new blood vessels becoming so active, so bleeding and leaking fluid, and help to stabilize vision. In a broad sense, that's really the main treatment option we've had up to this point. With dry AMD, treatments are now coming into clinical trials, or even there are FDA approved drugs in the United States as of this year, which is a big development in AMD, in that there's never been any form of drug therapy before for dry AMD. But I guess the other thing to say is we have to think about the whole spectrum of AMD, as we've just heard about, really the early and all the way through to the intermediate and late phases. So there are different approaches and different research going on for all those different aspects of it.
Thank you. Are there clinical trials underway in the UK that people could join for AMD, new treatments?
So can I answer part of that, and Sam answer the dry type? So for the wet type, there have been a number of trials at Oxford Eye Hospital, amongst others across the UK and across the world, that have been involved. So in the last 5 years, we've been involved in at least 7 trials in this area. And we are still involved in trials, but mostly at the moment with the wet type, in examining response to treatment, examining biomarkers, by which I mean things that you see at the back of the eye in the imaging that can tell us whether or not someone is responding or will respond well to certain drugs. Because we have for example, here at the eye hospital, we have 4 in use at the moment. And of those drugs, some people respond better to one type than another. And so we're very interested in looking at the genetics of the conditions. We're also very interested in looking at these biomarkers, as in what can we see on the imaging in our research that tells us that this individual will respond better to this number of injections or this particular drug. So that's that side of it. All of the approaches to do with gene therapy for the wet type are just about to come online. We're involved in studies here. We are currently have 3 that are hopefully we're going to be starting to recruit to shortly. And that's for the wet type, where it is possible to deliver the gene that's affected to the back of the eye with an operation to deliver that into the eye, to try to replace the gene or alter it in a way that would help replace what is missing or prevent what is not working properly, i.e. aid it to work better. So Sam, do you want to talk to the dry type?
So again, there are multiple research studies looking at dry AMD, or specifically geographic atrophy, which is the advanced form of dry AMD. And it seems like things are really kind of exploding in some ways in terms of this area of research, with novel therapies and approaches that really weren't available a few years ago. And there are sort of multiple different lines of investigation. So in terms of the dry or advanced AMD geographic atrophy, the newly approved drugs in the US are looking at blocking a protein called complement, which is involved in inflammation, so sort of inflammatory responses in the body. And so there are some trials ongoing assessing those drugs. Those patients have already been recruited into those studies, but there are ongoing trials looking at how effective those treatments potentially are. In terms of dry AMD as well, there's gene therapy. So there are gene therapy studies either by injecting a gene therapy into the eye, just as you would a wet AMD type injection, so into the sort of a normal injection, or a more complex operation to inject gene therapy under the retina to see if you can restore some of those proteins that are required to maintain the health of the retina and the cells at the back of the eye. Moving on from that, there's also stem cell therapy, looking at whether you can, the currently recruiting stem cell trials are not trying to replace the entirety of the area that's been lost, but trying to replace one layer, what's called the RPE, the retinal pigment epithelium, which supports the retina. It sort of provides the nutrients and helps it to survive. And so there are some trials looking at whether, introducing a healthy RPE could also help to support vision and stop it declining, amongst many others. So there are, multiple people looking at things from different angles at this stage.
Thank you. There was a great deal going on. So to move on to our next question, my mother suffers from AMD. Is there a test to predict the development of AMD in healthy individuals whose parents have AMD? So I think if you can explain a little bit about the genetics when you've got AMD running in your family, that would be helpful. So
this is an area that actually both of us are very interested in, and Sam is actually conducting a trial, not a trial, more of an observational study into this at present. But briefly and overall, if you have AMD in the family, i.e. if your parents have had it, then you are at a higher risk of having it or getting it yourself. It doesn't mean it's absolutely that you will get it, but you are at a higher risk. If you also look at the genetics of age-related macular degeneration, it's actually quite difficult. There are multiple genes or multiple variants in genes that can give rise to age-related macular degeneration, and it's known as what we call a complex disease because more than one may be interacting, and therefore this is why it's so difficult for us to get to the bottom of exactly what is causing the AMD in particular individuals. So as yet, there is no particular list or panel of genes that we can, in the NHS, say, right, we're going to test for all these and see if you have one of these in a family, because we're not ready for that yet. But this is what's going on in the research side, and that's the sort of aim. Interestingly, in the background, there was a recent paper on looking at taking blood tests from people and looking what they found in the blood that may be associated with certain features at the back of the eye in age-related macular degeneration. And they found that certain, because I talked earlier on about biomarkers, as in appearances in the scans at the back of the eye, what specifics can we take from those images to say this person's going to do better with this drug or worse with this drug? In the same way, one research group have looked at the features at the back of the eye and mapped them to taking blood from someone and looking in the blood for certain biomarkers in the blood that predispose people to have particular features at the back of their eye. So that's another area. So that would come on to environmental, dietary, and general health in addition to genetics. So I've gone around the corner a bit. I don't know, Sam, if you wanted to add something to that.
Yeah, I mean, I think the difficulty with AMD is that it's multifactorial, as we've just heard. So as well as the genetic components, and there are known genetic risk factors, although we, as Professor Down said, we can't test for them routinely in clinic at present. But we also, there's strong evidence that diet and lifestyle factors play an important role. And so in terms of the original question of predicting progression, it's really dependent on all of those things. So we know that smoking is an accelerating factor. Smokers, are more likely to develop AMD and also more likely to progress if they have AMD. We know that diet plays an important role. So there are multiple studies looking at diet and different aspects of diet. So more recently, Mediterranean diet has been shown to be protective. So those who have a sort of Mediterranean diet there's a very big study in the US that started about 20 years ago, but has really kind of led the way in a lot of these, this evidence base called the ARED study. And people may have heard of that in terms of that's the basis of which we advise a lot of the lifestyle, give a lot of the lifestyle advice that we do in AMD. And so part of the ARED study looked at a lot of these different things. And one of the papers from that looks at Mediterranean diet. There's also looking at oily fish, not smoking, as we've said, and a number of other epidemiological studies around the world. The Blue Mountains Eye Study, the Rotterdam Eye Study have shown similar findings. So so that's partly why it makes it difficult to know who's going to get worse and when, because we don't know exactly how all these factors interplay in one individual.
Thank you, but there are things people can do to help slow the progression, and they mainly boil down to a healthy lifestyle, if that's right.
That's a reasonable approach, yes.
Which can help lots of things, not just your eyes.
Which usually brings us on to the question that most people want to ask is, should they be taking, in addition to the healthy diet and stopping smoking, should they be taking the age-related eye disease study 2 micro supplements? And that's a very interesting question. And if you read the evidence and the review of the articles, then there is a group of individuals with certain features at the back of their eyes which suggest that they would benefit from taking this group of minerals high, in a higher dose than you would normally have from a diet. So the ARED study 2 recommends a list of particular micronutrients, I call it, that could be helpful. And there is no point in taking that unless you have the very specific features of age-related macular degeneration, which are characterized by some early to intermediate changes. If you already have, for example, in both eyes, wet age-related or dry age-related, then in a sense, the horse has bolted, and it would be better to stick to a good diet rich in highly colored vegetables and oily fish. And with the oily fish, we tend to recommend taking it twice a week. And you can take any other fish as well if you wish, the Mediterranean diet, but take the oily fish twice a week if you can do it. We don't say take it more than twice a week because some of these oily fish carry a little bit of heavy metal as well. So it's everything in moderation, but the Mediterranean diet does seem to be the way forward.
Thank you very much. It's a very interesting subject, nutrition. So to move on to another area, somebody's asked about the AMSLA chart or AMSLA grid and how often they should be using that. So if you could explain a little bit about what the AMSLA grid is and how often they should be using it.
Sam, shall I just nip in for that one as well?
Yeah.
So the reason I've chosen to answer that one, which is the AMSLA grid was designed basically to help people monitor their vision. And most people, it's recommended that you check it once a week. And if you check it once a week, you have to check each eye separately. And you either do it with no glasses on or your reading glasses. If you do it with varifocals, it's actually quite tricky because you can actually, it appears to be more wavy than it necessarily is. So the point of checking it is to elicit for any changes on that grid, which would include a blurring of the center. So you have to focus on the dot, blurring of the center, bits missing from the center, distortion. So if there's a wiggle in the lines, and if these are new features and you check it with each eye separately, because the brain's very clever at ignoring abnormalities because the other eye fills in. So that's what I would recommend. But very interestingly, we're doing a research project here at the Oxford Eye Hospital, which is called OCCO, and it's an innovation-supported project, which is to try to use, for example, a smart device like a telephone, where you can actually almost play a game where you touch the dots, and if you can see them all, and you touch them all, the device will record that, and you'll be able to be, in a sense, reassured that as you can see the dots, you haven't yet developed an issue. And we may even be able to use it to monitor between injections, because as you know, the NHS is under quite a lot of stresses and strains at the moment with the number of people coming through. So it might be a way of self-monitoring. So that's essentially the answer to the question. It doesn't have to be an Amsler grid. Some people say they prefer to look at their clock in the kitchen or at a novel that they're reading or whatever they're doing. But it does have to be something that you can monitor change. And perhaps the Amsler grid is good because you can draw on it. So as a baseline, any wibbles or wobbles or whatever that are already there, you can have it as a baseline.
Thank you. So the main message is, if you notice changes to your vision, seek professional advice. Yeah,
that's right. And most people check it once a week. Some people check it more frequently. It's very much up to the individual, but you don't want to become such that it drives you rather than it being something to help you check your vision. But if you want to check it more frequently, that's fine as well.
Thank you very much. Okay, the next question is about genetics research. Somebody has written in the chat about that their mum has AMD. Could she take part in genetics research? So maybe you can tell us a little bit about how to get involved in research generally as well.
Yeah, so there are sort of several avenues for getting involved in research. So there are a few websites, such as the NIHR website. So there's Be Part of Research, which is the NIHR scheme that has launched relatively recently. And you can go onto the NIHR website, sort of type in that address, and it will let you search for all or many of the research studies that are currently recruiting, that have sort of engaged with the NIHR website. So it will allow you to see what's in your local area, and you can volunteer or go onto a register. And if you're on that research register, us as researchers will also look for participants as well through portals, similar portals. So you can, it's a two-way thing. You can get in touch with people, but we can also then get in touch with you. And many of the eye hospitals or research departments will have similar things. So at the Oxford Eye Hospital, we have a eye research register. So any patient who wants to take part in research can go onto our Ergo research register, and as soon as we have a trial that's recruiting or something that they may be interested in, we'll then reach out and contact them. So it's really worth getting in touch with your local eye department or the NIHR. Also charities often have patient meetings, updates on their websites, Macular Society, RNIB. And so, there are multiple sources of information, as well as local eye charities. So in Oxfordshire, we have My Vision Oxfordshire. So do reach out and get in touch, because we are also very keen to get people involved in research. It really does help us to have volunteers who are willing to participate, who are obviously suitable for the relevant clinical trials.
Excellent, thank you. So to move on to the next question, it's about symptoms and whether, if you've got symptoms in one eye, you're likely to develop symptoms in the other eye. So to what extent are eyes affected in a similar way with AMD?
So with age-related macular degeneration, if you have gone from the early phase in both eyes. For example, if one eye becomes involved with wet AMD, age-related macular degeneration, then it is said that you have a 10% chance per year of the other eye becoming involved. So yes, there is a risk to the second eye. It's not inevitable in everybody, but there is a higher risk if you already have it in one eye.
Is that the same for dry AMD, late stage dry, geographic atrophy?
That probably is even more symmetrical.
Thank you. Next question. Does AMD cause general blurriness, or is it more blank spots in your field of vision? So what are people actually experiencing when they have AMD?
I think this is difficult because it's everyone sort of, there's a range of symptoms that people describe, but the common things will be distortion, so straight lines looking bendy. So rather than an edge of a door or window being completely straight, it may have a kink in it, it might have a bend. Often reading can be an early sign, so difficulty reading, letters, words being jumbled, letters, words not aligning on a page. And as things progress, then the disease is a disease of the central vision, so that can be more patches in the vision being missing, difficulty seeing faces, difficulty seeing, being able to read things from further away. The peripheral vision in AMD is not affected, so that edge of the retina remains healthy, so it tends not to affect ability to walk around a room or navigate, but it's that central, and obviously that's the key part of the vision we do use. So it can be anything ranging sort of in the early stages to a little bit of distortion or difficulty reading to more central vision loss, so black spots or inability to see details.
And night
to add anything to that.
Sorry, and night vision is affected as well?
So if I could add firstly, before the night vision thing, that absolutely encapsulates it, Sam. The other thing I would say is, of course, we do know there are other chronic or acquired eye conditions that can give rise to blurring, such as cataracts or becoming long-sighted. But if you notice any new changes that are different, and particularly unilateral in one eye, then it is very important to get it checked. So any new onset of blurring or distortion in one eye is important to get that checked on an urgent basis. With the question about night vision, generally speaking, this is not a condition that causes night vision problems, but even in early age-related macular degeneration, some people notice that they're a little bit slow to dark adapt. What I mean by that is, if you remember when you go into the cinema, sometimes it takes a few seconds to accommodate or get used to the dark. Now, in conditions where the macula, which is the center bit, is affected, in some people, they notice they're a bit slow to dark adapt. So if they've been in bright light and then they go into the dark, it takes them a while. But they're not what we would call night blind, in that they can adapt. They can actually see in the dark. But the first stage of going from light to dark can be difficult, which is why driving sometimes, even when you've got early age-related macular degeneration, can be difficult, because you can get dazzled by headlights and then take a while to accommodate back into the dark.
Thank you. So to move on, we've got another question on supplements, and this is specifically about lutein and carotene. Are those beneficial on their own, or would you suggest sticking with AREDS 2 formula?
So the best evidence out there is really the AREDS formula, and what that is a Preston said earlier, a combination of vitamins and minerals. So essentially there were two big studies. The first one was AREDS 1 and then AREDS 2, and the vitamin supplements include vitamin C, vitamin E, zinc, and in AREDS 1, beta-carotene, and in AREDS 2, lutein and zeaxanthin. And what the two studies showed is they're about equivalent in terms of their effect on reducing progression to advanced AMD. So the only strong evidence we have is using them in that combination with the other vitamins as well. The studies looking at other things individually are less powerful, so there's less evidence to support them. So personally, the vitamins I would recommend in clinic would be that specific combination, the AREDS combination, rather than taking individual vitamins separately. Although, as we've discussed before, a healthy balanced diet is probably the most important thing in terms of long-term benefit and risk minimization.
Thank you very much. So the next question is about the wet versus the dry form of AMD. And somebody's asking about the risk of vision loss associated with both those types. And can you get both wet and dry in the same eye?
Okay, so let's take the last question first. The answer is yes, you can get both wet and dry in the same eye, or one in one and one in the other. So that's the bottom line, you can. And then they are different, and they're different because one is characterized by wear and tear of tissues. Sometimes people don't like that word, wear and tear, or a bald patch on a tire is my other analogy. But it's basically where the cells and the tissue is just not working properly, and it's almost died away in a little patch in the dry type, otherwise known as geographic atrophy and dry. And in the wet type, new blood vessels grow in. And the difference in the types of visual disturbance that occur, Dr. Silva was talking about that a bit earlier, but basically with the wet type, you can have sudden drop in central vision because there may have been a little bleed from the blood vessels. And I will say at this point, out of interest, if there is a bleed such as that suddenly occurs, we are doing a study at the moment looking at displacing that blood to see if we can improve matters. And that's a current study that's going on at the Oxford Eye Hospital. Having said that, you can usually with the wet type, usually you get a warning, which is distortion, blurring, or as we talked about earlier, wiggles in the vision. And with the dry type, you may not notice much change over time until it progresses a bit and it comes into the center of the vision where the cells just don't work so well. So both of them are characterized by central visual impairment, which can be different and can take, so the wet type can be quite quick in terms of change, but if it's treated and responds to treatment, then you can stabilize. You've got a 40% chance of improvement in some cases, and you've got a 90% chance of stabilizing with the treatment given at the appropriate intervals and at the right time and in time. With the dry type, we wait for the new trials to come through and for the treatment to be available to see if it will slow it down and prevent further deterioration of that central vision over time.
Thank you. This is why at the Macular Society we always encourage people to, if they notice any changes to their vision, to get straight down to their optician, because if it's wet AMD, they will refer you into the hospital straight away for treatment. It's really important you get the treatment quickly if it's appropriate for you. Thank you. So our next question is, somebody's been diagnosed with early signs of AMD and what they referred to as bumps, which I'm going to interpret as drusen, on the macula, but she's been told that they indicate it will be wet AMD. So can you explain the difference and how one can tell? So,
Yep.
I've had drusen by the look of it, maybe.
So there are different types of bumps, which is one place to start. But essentially in AMD, what we see is there are different stages, sort of as we've discussed, but mainly those are based on clinical examination. So what we see when we look in through a lens to the back of the eye, and also imaging. So OCT scans are now what we use to diagnose AMD and to monitor it, both in terms of progression or response to treatment. And what that involves is infrared light that really visualizes the retina in very, very high magnification, so sort of in micron level detail. And so in early AMD, what you see are these bumps under the retina. Those are drusen. They're essentially not everyone likes the word, but waste sort of deposits where the eye can't clear the natural byproducts of the vision process of vision, and those build up under the retina. And those can get bigger and they can coalesce into larger drusen, which we call intermediate AMD. And that's really a precursor, and that can go one of two ways, to wet AMD or to dry AMD, geographic atrophy. So we still don't know exactly what, causes progression in one direction versus the other. So when we see those early changes, we can't, at the moment, predict exactly what's going to happen. And there is a huge amount of research going on into that. So there's a big study in the UK called the Pinnacle study, looking at artificial intelligence to try and look at patients with intermediate AMD. Oxford was one of the sites recruiting for that study. It's principal investigators Andrew Lotry in Southampton, and so looking at artificial intelligence to try and map that intermediate AMD and work out which way it's going to go. There's also other predictive tools. Moorfield has a big artificial intelligence unit who we work with as well, trying to look at different features and understand how we can predict disease progression and disease severity. So it's a big unknown, but there is a lot of work going into that, because it's obviously a key question that patients want to know, and we want to know as well.
Lovely, thank you very much. So the next question is about a form of slow release treatment. So a system of inserting a slow release storage unit of drug used to treat wet AMD, thus reducing the frequency of injections. Now, I know that there's a lot of research going on to move away from quite so many injections, or even remove away from injections so far. So I think this might be about the port delivery system. If somebody could talk about that.
Yeah, I can take that one. So essentially, as well as there's research into multiple different aspects of neovascular AMD at the moment. So we've got newer drugs that are now available, so those that are NICE approved. As we said, we've got sort of 4 NICE approved drugs for neovascular AMD now, and some of those are longer acting. But as we know, one of the problems with giving with these medications is they have to be given often, and some people need frequent injections, so 4 or 6 weekly injections to keep their disease under control. So what one of the companies has developed is what's called a port delivery system, which is essentially a tiny little vial or storage device that's implanted into the eye. It just goes through the white of the eye and sits under the surface of the eye, and that is a slow release of store of ranibizumab, or what was Lucentis. And that gradually releases the medication over 6 months. So the idea would be that only needs to be filled every 6 months, reducing the need to come in and have injections. It's very much still in clinical trials. There have been some technical issues with the actual design of the port, which I think are now resolved. But it's something that we're looking forward to seeing what the outcomes are of the trials going forwards. But alongside that, people are also trying to develop longer acting injections. So we do know that some of the newer agents in clinical trials, patients were able to even go up to 4 months between injections. And so part of those real world studies that we mentioned that are now going ahead is to try and evaluate whether patients respond in the same way in clinic as they do in those clinical trials, because we all know that clinical trials are a very, very controlled environment, and we get the best possible results we can. Whether that translates into the real world and patients show in clinic those same results is a different question. And so a lot of centres are recruiting to these real world studies, and it's definitely something that most patients having treatment can get involved in or sign up to in different units. So that's sort of complementary to that port delivery system that we were talking about.
Thank you. What about, are there any less invasive treatments like eye drops or tablets that are in development?
People are looking at eye drops, but it's still very difficult to do.
Can you explain why it's difficult? People might imagine that eye drops would be easy.
Because when you put it on the surface of the cornea, it has one form, but you've got to get it to be able to pass through the cornea itself and get through the vitreous gel to the back of the eye and the cornea. So you have to change, I'm not a chemist, but my understanding is that you have to change the structure of the drug in order for it to pass through, for example, a lipid barrier versus an aqueous barrier, etc. So it makes it quite difficult for something that you're putting on the front of the eye to get to the back of the eye.
Okay, so it's a technical issue of getting enough drug to the back of the eye, but an injection gets the drug right to where it's needed, which is why it's preferred.
Yes. I probably haven't explained it very well. Sam, do you have anything to add to that?
No, I don't think so. I think it's just that you know, there are so many physical barriers between the front and the back of the eye, and trying to get a drop to penetrate all the way through has been challenging. But I think,
yeah, because some people might say, well, you can get it for glaucoma, and the glaucoma problems at the back of the eye, why can't you do it for AMD? But it's a different drug and it's a different target.
Thank you for explaining that. So the next question is about sort of the progression to wet AMD. Is there anything that could prevent you developing wet AMD when you've got the earlier stages of AMD already?
So this comes back to preventative. And so we've talked a bit about diet and vitamins, and there's some possibility that maybe light might be toxic to the back of the eye. Yet there are studies looking at using light to try to reduce the burden of the drusen, to try to reduce the number of drusen and therefore the predisposing feature towards developing the advanced form of AMD. But I still remain to be a bit convinced about that. I don't know if you have any comments on that, Sam.
Yeah, I think we need more evidence to know a bit more about those treatments at the moment.
So photomodulation of the back of the eye. There were studies earlier in the late 90s and early 2000s about lasering the back of the eye. They were abandoned because of the high risk of developing wet type afterwards because around the laser scars. And then radiotherapy was also used to see if that could be helpful, and that was also abandoned. But this other more recent approach has been looking at a different wavelength of light. So I wait to have more evidence.
Thank you. Yes, it's still being investigated, but it's an interesting area, I think I'd say, but yet not proven yet. So somebody's asked about before we had injections of anti-VEGF drugs for AMD, there was laser used to seal the blood vessels,
so that
which caused a
was
lot of damage. Yeah.
So photodynamic therapy was used in the mid-2000s, and in certain patients it did cause a problem because in age-related macular degeneration, the retinal pigment epithelium, which Sam mentioned earlier is the nourishing layer underneath the retina, sometimes became rather worn out after having received the laser dose. So you might be able to switch the blood vessels off, but it gave rise to a secondary wear and tear, atrophic type tissue, really not responding well to that laser. And that was because we used a higher power and a higher dose of the photosensitive dye. Interestingly, we do still use that laser, the photodynamic therapy laser, for central serous chorioretinopathy, which is the fourth most common macular disease after age-related macular degeneration. Prior to that, we used direct photocoagulation laser, which is thermal laser, which we just used to try and burn the blood vessels and get rid of them. It sounded good, but unfortunately it was abandoned unless the blood vessel was way off the center because it caused so much destructive change to the center of the retina, as in the macula. So that approach is not used in age-related macular degeneration and hasn't been used since the advent of injections.
Excellent. So laser is more, there's more than one type of laser, there's more ways of using laser.
Correct.
That's what I'm hearing. Okay.
Yeah.
Thank
The
you.
only thing I could add to that is there is a subtype of AMD called polypoidal choroidopathy, which is a sort of a subgroup within the big umbrella of wet AMD. And for that condition, there are some trials that have shown that a combination of the PDT laser and injections can be effective. So that is probably the only time that we would consider using PDT in sort of the AMD spectrum at the moment. But saying that, there's a worldwide shortage of the dye used for PDT laser at the moment. And so in practice, that's not happening in most units currently.
Thank you. So there's a few questions about the injections that people are given for wet AMD. Can you explain how they work and how long they last? And if they are, I'll come to that next one after this one. Sorry, I won't bombard you with too many questions at once. So it is how the anti-VEGF injections work and how long do they last?
Sam, do you want to do that one?
Yep. So as we've said in wet or neovascular AMD, the problem is that you get this growth of abnormal blood vessels under the retina. So what these injections are, they block a molecule called VEGF, and that's VEGF essentially causes proliferation or growth of these blood vessels. So it's a sort of activates blood vessels and makes them grow in the Right, we need some of it for our natural, blood vessel development, but this is happening excessively. So essentially the molecules that we inject into the eye, they block that VEGF, and so the blood vessels shut down and they stop bleeding and they stop leaking. There are different VEGF inhibitors, so we've now got 4 that are NICE approved for wet AMD. All have long, complicated names, but ranibizumab, or what was previously called Lucentis, we now have biosimilars for that, aflibercept or Eylea, brolucizumab or Beovu, and faricimab or Vabysmo. And different clinics will use different treatments dependent on their local protocols. But we know that some of these agents in the trials last slightly longer than others. So they, in theory, could last anywhere between 4 weeks to potentially up to 16 weeks, but every patient is different. And so essentially what happens is you have an initial course of monthly injections with all of these medications. And then in most units, the way that protocols work is you then tailor the frequency of injections to what we see in terms of clinical examination and what you see on the scan. So if vision is improving and the scan looks like it's getting better, then you tend to carry on with the injections but extend the gaps between them. Or if the scan still looks quite active, you may need to stick with 4 or 6 weekly injections. So so really, it can be quite variable dependent on the individual. It's a tailor-made approach to that person's eye and how they respond to the drug, but anywhere between 4 weeks or even 16 weeks. Some studies have even gone up to 20 weeks between injections.
Yeah, it's amazing the progress that's being made. So if you're having treatment for your wet AMD and injections, can you tell me a little bit about how the treatment progresses? When you having injections for the rest of your life, or how does that work for many people?
So just to follow on from Sam there, for some people, they are lucky and they don't have to have as many injections. For others, they continue with injections. Even if you manage to get the injection gaps longer, they may still need to have injections long term. Now, what do I mean by long term? Most people, in our information leaflet that Sam and I have written for the eye hospital on AMD, most people are going to be at least on a 2 years minimum. to start with. So if we just put out there straight away, then when you go to this protocol of treat and extend, which is where you treat an eye that shows activity on the scan, you look at the vision, you look at the scan, and you determine whether the eye is responding to treatment. So if it is responding well to treatment, then you can extend the gap, which is why it's called treat and extend. If then the eye is not responding well to treatment and they have been on a certain agent for a while, it is possible that the eye has become as almost resistant to the treatment. That doesn't happen in all people, but it can happen in a proportion. So we may well alter the drug that they're on, change them to a different drug, or increase the frequency of the injections. We have some individuals who come off the injections altogether, and in that group, they still need monitoring. So they may need to be with their community optometrist, and they also need to be aware, as we talked about the Amsler grid before, that checking each eye separately is still important, because even when you come off treatment, even if you haven't had it for 2 years, there's been a gap that long, it is possible to have a reactivation. So it's individually tailored. It starts as treat and extend in this unit, and most units across the country are doing that approach. Another approach is as the need arises. And what that means is you treat if there's activity as it occurs. So if you've come off a treat and extend, where you've been in a program and every time you're seen, you have an injection, and then you extend it a bit, you have an injection and a scan, and you extend it a bit further. If you manage to come off treatment altogether for a period of time, then in a sense, you're moving on to as the need arises. So you would be treated if the condition flared up again.
Thank you, that's clear. Slightly different type of question. Somebody's asked if their husband has glaucoma, can this develop into macular degeneration?
No. It's a common condition as we all age-related macular degeneration, glaucoma and cataracts are the 3 commonest things we see. AMD is the commonest cause of visual impairment in the central vision that's not reversible. Glaucoma is a separate condition, causes a different type of problem, but it can coexist. So it can be another condition. Because people get older, they are heir to these diseases, and therefore it is possible to have cataracts, glaucoma, and age-related macular degeneration. Doesn't mean that you always get them all, but your likelihood of getting them increases with age, particularly if you are an individual who is susceptible to those. Again, with glaucoma, there is a complex inheritance possible, variants that predispose people. There are families with glaucoma. So again, it has a hereditary component to it, but it's also an aging multifactorial situation as well.
Lovely, thank you very much. So next one is something I've not heard of before. Is there any information on how hyponatremia affects eyes?
Not as far as I'm aware. If your salt level is very low, and you'll probably be feeling pretty, if it's severely low, if your salt's severely low, I'd imagine you'd be feeling pretty unwell all over, and you may get blurred vision, but I don't know of anything to do with age-related macular degeneration. So,
sorry, could you just explain what hyponatremia is? You suggested
I don't know what particular condition that the question person has asked, but right. As a condition, it's not common, but it can be that people can have a low sodium.
Right, okay.
That's what I assume is the question.
Yes.
But it's more of a systemic issue, and it's not something that I would associate with any of the conditions that we've been talking about just now.
Right, I understand, thank you. Next question is there a way to tell if dry AMD in the early stages, so what we're referring to as early AMD, will get worse? Is there a way to tell if you might progress to the later stages and vision loss?
So I think this is similar to one of the other sort of question about the drusen and the bumps progressing. So really, there are known risk factors. So we know that some there's some genetic predisposition, there's some lifestyle modifications, so smoking, diet, etc. But I think this is information that we're going to hopefully get out of the artificial intelligence studies that are being done at the moment, because I'm not sure if Susie wants to add anything.
So one thing I will add to that, other than the studies that we're doing, is that there are certain shapes of the drusen that over the years people have characterized, people have looked at these drusen and described them. And drusen are, they're complicated, but they are, think of it a bit like I call it a bit like a waste disposal unit that's got a bit clogged up at the back of the eye. And it results, because the eye is one of the most active parts of the body at that macular area. And it's in the cell is dealing with vision, dealing with all the byproducts of vision and trying to, as it were, think of it like trying to shovel it out of the cell, get rid of it, because it needs to be cleaned away, ready for the next action. And during this time, the cell undergoes a lot of activity. And if you don't get rid of the debris, it builds up. And the build-up is, we call it a drusen, which is actually a German word for geode, in fact. But anyway, and singular is druse. But inside this cell, and sometimes on top of it, is this debris, which needs clearing away. And some of these different types, depending on their shape, distribution, and what they look like, we can sometimes infer from that as to whether they are high risk for developing a later form of age-related macular degeneration. We do see some little hard drusen in the periphery of the retina, which makes it, these type are an aging change, a natural aging change usually, which probably doesn't really predict any onset of age-related macular degeneration. They're just an aging change. But there are certain types of drusen that are highly suggestive, if that is the question that was being asked. In terms of the artificial intelligence, huge studies looking at masses and masses of imaging and data are looking at, can we predict what types of image biomarkers, I mentioned biomarkers in blood, what type of, and when I say biomarkers, just to repeat that, features of the scans are going to tell us that this individual is going to develop age-related macular degeneration of this type, as in dry or wet, and which ones are going to respond well to the different treatments. So big studies going on, and we're doing a lot of work here on that, and liaising with Moorfields and other sponsors who are very interested in developing this.
Thank you. We're very close to the end of the time that we've got available to us. So would one of you just like to have a sum up where you see research going in the next few years? Anything you're particularly excited about?
Let's share that. Sam, you want to start and say what you...
So I think there are so many areas that actually, it is an exciting time from the research perspective. So as we've sort of touched on right at the beginning, one area is dry AMD or geographic atrophy. There are so many trials in that sphere at the moment that have really not been for a condition that we've not had any therapies for, as yet, but hopefully coming. So, we'll watch this space and see what the trial results show over the next few years.
And I would echo that and say observational. So lots more information about what we see, reporting that into a large database with analytics that go with it, bioinformatics that go with it, and put into that. And this is something that Sam and I are doing, looking at all the genetics and the environmental factors and the features to see if we can tease out who's going to benefit from what and how we should address it. Also, another exciting area other than genetics is something called optogenetics, which is where you might be able to use the cells that are still working in the eye that are not the actual photoreceptors that capture the light, the cells that are the second ones that take the message off to the brain. Maybe it might be possible in the future that we are able to manipulate those not only to take messages but to sense vision as well. And I think that was the subject of your PhD, wasn't it, Sam?
Yes, it was. And I guess the another thing is that even though we've got many anti-VEGF agents, there are lots of trials looking at others. So even longer acting drugs, different pathways to block. So again, lots of work going on to see if we can get more effective injections that last for longer.
And my last line on it, because I always have to have the last word, is that when I started this, there was nothing. And in the mid-2000s, there was PD photodynamic therapy. And then immediately after that, by about 2007, 2008, came the anti-VEGFs, the injections, which completely revolutionized the treatment. So watch this space.
Thank you. That's a brilliant note and a very hopeful note to finish on. So thank you so much, Susan and Samantha. And thank you for everybody providing your questions in the chat. I'm sorry we didn't get to all of them in time, but I really hope you found it a lot of very useful and interesting information. And thank you to our hosts, the National Institute of Health and Care Research. If you want to learn more about research and how you can take part in studies, a reminder to look on that Be Part of Research website. We've put a link to an evaluation form in the chat. If you could take a moment to complete that, that would be really helpful. We'll also send you a link to the form and a recording of tonight's event via email. We want to run more of these events, and we want to know what we are getting right and what we could be improved. So please do that evaluation for us. Just remains me to thank Susan and Sam and NIHR for this really very interesting webinar. So thank you very much and good night.